Okay, welcome to our KnowEMS webinar today. On behalf of the KnowEMS consortium, I would like to briefly introduce the KnowEMS project to our partners that are joining the webinar. For this, I will share my screen. Now you should be able to see it. The KnowEMS is the abbreviation of the Knowledge Network of Workable Emergency Medical Systems, and it is a project co-funded by the European Union. KnowEMS started in January 2025, and it will be completed in the end of December of this year. The consortium behind the project consists out of 7 organizations representing 6 different nations. Here we have the Johanniter Unfallhilfe in Germany, we have Magen David Adom from Israel, the National Institute of Medical Emergencies in Portugal, we have the Department for Emergency Situations within the Romanian Ministry of Internal Affairs. Then there is Ayuntamiento de Madrid from Spain, the Société Française de Médecine des Catastrophes from France, and last but not least, Assistance Publique Hôpital de Paris, also from France. These are the project partners coming to KnowEMS. KnowEMS builds up on a further project called No Fear, in which it has been identified that there's nearly no network existing for emergency medical services to exchange knowledge on a national level. So, for example, during COVID, this was a great challenge. As you all might very well remember, the pandemic has reached a different level in various countries at the same time. So the access to already existing knowledge and lessons observed on different measures could probably have helped to overcome this pandemic a little bit more smooth. So the KnowEMS builds up on this further No Fear project. In the KnowEMS, we are now creating a network of EMS operation managers with involvement of civil protection and public safety actors. And we are organizing monthly webinars, such as this one today, to discuss topics of interest to give EMS staff and EMS operational managers the opportunity to learn from each other. Therefore, we invite presenters from organizations and authorities all over Europe and beyond to share their very specific experience. And also, we share the knowledge accumulated in the KnowEMS sessions through the knowledge network of the EU Civil Protection Mechanism and through other fora with the public. Last but not least, if you don't want to miss any of the upcoming webinars, become part of our network, if not already done, and register via the QR code. And for those of you who would like to receive a certificate of attendance for this webinar, please stay with us. With the last speaker, we will share a QR code as well as a link in the chat where you can register to get one. With this being said, I would like to hand back to you, Hwang. Yeah. Many thanks.
Thank you very much. Thank you very much, Lisa. Thank you for being with us this evening. I see people also from other continents. So for some of you, very good evening, and for the others, very good morning. A pleasure being here with you. My name is SAMUR P.C. I'm the Disaster Management and International Cooperation Coordinator of Magen David Adom in Israel. Magen David Adom is part of the International Red Cross and Red Crescent movement. We are the national provider for emergency medical services, EMS in Israel, and the National Blood Bank. But I'm here under my umbrella or job as the International Cooperation Coordinator to moderate a fascinating webinar around surge in pandemics or surge in health emergencies. And we are going back to those days of COVID, where COVID was everywhere and the system was very, very short of qualified personnel. And one of the solutions that was found was to extend the role and responsibilities, which are normally well defined and even legislated for nurses and paramedics and EMTs in the field, and the international experience is international experience, but we have national experience, and then suddenly we had to open the doors and let people do things that they can do and never did before. So we will have three wonderful speakers this evening. A representative from the Ministry of Health of Israel, Ms. Keren Mekadesh, Dr. Christine Hwang from the Canadian Red Cross, and Ms. Paloma Rey, our dear friend from SAMUR Madrid. I don't want to take your time, so Keren, please.
Thank you very much, Chaim. So my presentation focused on how to expand the medical workforce in the times of emergency. During the COVID-19 period, we mainly expanded the number of nurses with advanced training.
I will just interrupt you because if you want to share your presentation, it's not on the screen.
Yeah, I know that
okay.
I didn't share it yet because I just want to add
no
that,
problem.
yes, we mainly expanded the number of nurses and with advanced training in intensive care and operation theater, and they were granted extended authorization to perform medical procedure that significantly supported the patient care. So this presentation will focus on how to expand the medical workforce in time of emergencies. I will share the presentation now. So can you see the presentation?
Yeah, very well.
Okay. So hello everyone. My name is Keren Mekadesh, and I serve as the Director of Nurse Competency and Quality Assurance at the Israeli Ministry of Health. I also lead the National Human Resource Task Force within the Ministry Emergency Health Operations Center, responsible for mobilizing and coordinating the health workforce in time of crisis. So since 2019, the Israeli health system has faced a chain of extreme emergencies, starting with COVID-19 and then the October 7th war, Iron Swords, and most recently Operation Am Kelavi, the war with Iran. Crisis is carried out by the nursing division in Israel, a ministerial body established in 1994 within 13 departments, covering every aspect of the nursing profession, from licensing to professional development. It is headed by the chief nurse of Israel, Dr. Shoshi Goldberg, who also serves as a Deputy Director General in emergencies. She and her team manage the entire national health workforce. And the challenge that encountered, like everywhere in the world, Israel faced a severe shortage of healthcare professionals. During emergencies, the shortage is compounded by coordinating difficulties, information gaps, and issues of competency and staffing standards. We work according to two guided principles: ensuring functional continuity first and foremost. Hospitals, community care, geriatrics, rehabilitation, and mental health must all keep operating. This guarantees that essential service remains available to the entire population, even in time of crisis. But keeping the system running is not enough. We must also make sure that right people are in the right place at the right time. So matching a resource to needs is very important. This means bridging between demands from the field and the available workforce and reserves, ensuring that every request is answered with the appropriate level of staff and expertise. This is our model for a rapid workforce expansion is based on 4 integrated pillars. So the first one is mapping and maintenance. We began by conducting regular surveys of non-employed staff and building volunteer registries at home and abroad. This gives us a clear picture of available resource at any given time. But knowing who is available is not enough. The next step is to bring them in when they are needed. So the next step is recruitment and activation. We mobilize students, volunteers, and former professionals returning to service, combining both skilled and less skilled personnel. This ensures that we can quickly scale up capacity and system is under pressure. Once we have recruited and activated these people, this staff, the question becomes how do we deploy them effectively and on time, rapidly? So rapid and flexible deployment for this purpose, every hospital is required to pre-establish support capsules composed of experienced doctors and nurses in intensive care, surgery, anesthesia, and emergency medicine. These capsules are activated in time of crisis to provide skilled professional support with guaranteed deployment within 12 hours at the latest. Of course, recruitment and deployment staff is only part of the picture. We must also make sure that the teams can stay strong and resilient while serving in such demanding conditions. So the last one is retention and staff support. Therefore, we provide childcare service, emotional support, and resilience programs, ensuring that healthcare workers can continue to perform under extreme stress. This is also other measures that we included. We can do transition to special shifts and expansions from military service for key staffs. Pre-signed agreements with private institutions, childcare solution for health workers, children. So all of these steps led to real time and achievements that we can see here. So you can see here the achievements in some numbers. All of these steps led to, since from COVID-19, the system secured permanent workforce expansion, 700 doctors, 2,850 nurses, of which 2,550 during COVID-19, and additional 300 nurses during the October 7th for Iron Swords, 700 allied health professionals, and in addition, for 4,000 nurses completed advanced training in intensive care and operation theater aligned with urgent system needs. Surge capacity was further strengthened by the recruitment of about 20,000 students in nursing, medicine, and allied health professions, 10,000 domestic medical volunteers, and over 12,000 skilled international medical volunteers. So these achievements in numbers are important, but what truly matters are the lessons we have drawn. Let me summarize the key insights that guided us and continue to shape our policies. Our strategic foundation begins with scenario-ready and adaptive planning. We continuously learn from each crisis, making rapidly regulatory adjustment and redefining goals when needed. Yet, planning alone is not enough. We must also prepare our people, our staff. That is why we focused on targeted training and integrated resources, addressing critical gaps in real time and combining both local and international teams to expand our search capacity. Finally, all of this rests of sustainable infrastructure, investment in data systems, staffing standards, and volunteer frameworks that ensure continuity of care even under extreme pressure. This foundation translated into concrete outcomes. First, permanent workforce expansion with thousands of new positions created. Embedding emergency lessons into long-term system resilience. To manage this resource effectively, we relied on data-driven decision-making, using real-time monitoring and allocation models, and at the center of it all stands leadership and resilience. Nursing leadership embedded in national governance, safeguarding both the continuity of service and well-being of healthcare workers. Let me close by sharing this message that matters most for all of us. The ability to rapidly expand the health workforce in time of emergency is merely an operational matter. It is a reflection of resilience, flexibility, and mutual responsibility of the Israeli health system. Thank you very much for your attention.
Keren, thank you very much for a wonderful presentation. For all of you, please use the Q&A function. You can, this is your way of asking questions, and we will take the questions at the end. So please go to the Q&A and present questions. Keren, I will take the liberty as the moderator to ask you a question. One of the trends that healthcare systems, especially hospitals, see following COVID is a dropout. That there is a huge fatigue, especially among nursing personnel, and they are leaving the healthcare profession. Did you see it? Did you see the same in the Israeli healthcare system? Keren, you're muted.
Do you mean fatigue of the staff?
Fatigue of the staff that resulted in resignation of staff.
Yeah, we saw it also in Israel, but we, as I said before, we had program and support of the staff, and it's a little bit help to reduce these issues.
Thank you. Christine, over to you. Christine, you are muted as well.
Hello, everybody. Thank you for the opportunity to speak today. Can you share my presentation, please? Okay. Cenk, next slide. Just as an introduction about myself, quickly, I am a general and public health physician who has been an international delegate for the Red Cross since 2007. I've been deployed in various roles, including as a clinician in outpatient clinics, inpatient work in field hospitals, as a senior medical officer, public health specialist, and a coordination assessment role person. In Canada, I work as a clinician in rural settings, which includes emergency, hospital care, and outpatient clinic. And along with working in these rural and international settings, I've also been working with the Toronto Public Health for 27 years, 2 of them as medical director for the sexual health clinic. Next slide. So my time dealing with COVID was a little bit ahead of most people. You may remember in February 2020, there was a cruise ship, the Diamond Princess, that was off the coast of Japan with an outbreak of COVID on board. At that time, it was the largest COVID outbreak outside of China. And in time, people were allowed to disembark from the ship and was sent to various facilities around the island of Japan, or they were sent to locations to isolate, or they were sent back home, depending on what their COVID status was. And among those passengers were over 70 Canadians who could not return home and were required to stay in various places in Japan. So the Canadian government called upon the Red Cross to provide remote support to these Canadians who were on board the ship, something like an adjunct to the consular services provided by the Canadian Embassy of Japan. As the senior medical officer for the team, I functioned as a liaison between the Japanese doctors and the Canadian patients and families, translating not only the medical language, but cultural differences in medical practices. Those were the early days of COVID, and very little was known about the disease. Not much known about the incubation period, the modes of transmission, the symptoms, long-term effects. But by then we knew that it was a deadly virus. In fact, a lot of information that we got did come from that cruise ship, because we had an idea of when they would catch it, when they would have been exposed, and when testing would become negative in some cases. And I returned to Canada shortly after the pandemic was declared, landing back in Canada on March the 17th, just as the international borders were closing. Change slide. How you might remember how we were given restrictions worldwide to flatten the curve, to slow down infections in order to not overwhelm the healthcare system. I don't know about you, but in those days I had to flatten another curve. Next slide. Then in early April 2020, news broke out that residents were dying in long-term care facilities in Montreal, the second largest city in Canada. They were not necessarily dying from COVID. Many were dying just from lack of care. The facilities could not find enough people to work, either because they were sick themselves, or they were burning out working long hours, or from fear of catching COVID if they went to work. So the government approached the Canadian Red Cross for help again. And there are many of us on the international roster who can clear a schedule and be available to be deployed with short notice. Not only were we skilled, trained, and experienced in the management of deadly infectious diseases, but we're also good at adapting to new situations. And something I'm sure that many of you as emergency medical responders are good at doing. Can we change slides? Actually, no. Actually, can we go back to the last one? Thank you. At that time, as I said, we didn't know much about COVID, but us Red Cross International delegates knew quite a bit about infection control. We created a standardized system, color coding things green, yellow, and red, with instructions related to each colors that were easy to follow. Then we went into the facilities, discussed with the personnel, and agreed on plans. Then we created space and movement flow to help them minimize infection risks. Then we trained them how to function in these spaces. The green areas was where COVID was unlikely to be found. Yellow are areas of possible COVID, and red would be areas of known positive COVID. And we would mark these zones with colored duct tape, as you can see in this photo. And we would put signs up to make things clear and visible, as you can see on the wall behind me. We would instruct the personnel what each of these zones required in terms of PPE. So as you can see, there is a cart with the PPE and the signage behind it so that it becomes very clear for everybody coming in and out of these areas. So the green areas, the PPE is not worn. And if you're coming from a yellow or red zone into a green zone, you would need to actually remove your PPE. The yellow zones are where PPE is worn, and donning and doffing needs to take place between residents. And in the areas, red areas, are where PPE is worn at all times, but there's no need to don and doff between residents. And this method was so successful that what started out to be work in 10 facilities in one area of Montreal ended up being implemented in all the long-term care facilities in the province of Quebec. Can we change the next slide? Then someone had a bright idea. Would this system work in keeping inmates safe from COVID in penitentiaries? And penitentiaries are very interesting places to adapt the guidelines. There are things that are unique to these spaces. By definition, the inmates, because they stay put, they're not usually the ones starting the COVID outbreaks. It's usually the staff that come in and out in their daily work that introduce the virus to the inmate population. But once in the population, because of the close quarters and the shared space, it's very difficult to manage an outbreak. The other thing that's unique to penitentiaries is almost no one that work in penitentiaries have any health background or any experience with infection control. So what the wardens got was this huge list of things. I was told it was 80 pages long of things they had to implement for COVID guidelines in the penitentiaries. And because they had very little insight on why certain things were proposed, it led to some unusual setups. Another thing unique to the penitentiaries is that in any regular situation without COVID, there's quite a bit of juxtaposition of people who are in these cells. We keep the gang members apart, we keep known enemies apart, and adding COVID measures added another level of complexity to a already complex situation. Another thing is the penitentiaries, by definition, almost, have only one way in and one way out of most areas. And then in one facility, they actually tried to implement one of the things that were in those 80 pages, and that was to have different entry and exit points, which was actually recommended in a lot of general situations. But because most penitentiaries really have only one way in and one way out, in order to implement that guideline, they actually had people walking through the administrative office to the only other door out of the penitentiary, so that all the people who were working in there actually end up walking by all the people working in administration and actually increasing the exposure rather than decreasing the exposure as this guideline was meant to do. Another interesting thing is because the inmates are never left alone, which means that the group of people coming into work and the people who are actually leaving would never leave at the same time. You would have the people coming in, they would debrief, then the group that are leaving would leave. So because of that, the people entering and exiting are actually not, even though they're going through the same door, they're not going through it at the same time, which leads to not only creating the yellow, green, and red zones that we showed you earlier, but we included a fourth dimension, and that's time. Spaces that were green may become yellow or red due to movement, and we would change the spaces from red or yellow back to green by just cleaning up after the people have gone by. As you can see with the entry and exit door, which is also the same case with movement of inmates in whether they're red or yellow or green. I really enjoyed working in these penitentiaries. We had to take a given situation, and each place was quite different. And we used our infection control knowledge and experience, with consultation with the board and the staff, of course, to design a space that works for the running of that particular space. Very much like a very huge puzzle, and solving it was integral to the success of the penitentiary's COVID and prevention. Okay, next slide. In summary, utilizing delegates on the international roster can be good. We have experience with similar situations, in this case, infection control. We have flexibility, certainly in our schedule, to respond quickly. We have the expertise. In general, we are highly trained. And lastly, importantly so, we're quite used to facing new challenges and function well when approached with new situations. Besides, with the borders closed, there wasn't much to do but stay at home and twiddle our thumbs. So it was actually a great opportunity. Next slide. Thank you for listening.
Christine, I never thought about the things you said. I will ask, sorry, I'm going to throw a curved ball on you. I understand in a long-term care facility, which is health-focused, that when you come and you offer expertise, you are more than welcome. In a system like penitentiary system, how did they accept you?
We were lucky because before we started it formally, we actually had a test site. We tried it out in penitentiaries in one place, and luckily it was successful. Successful enough that they were able to get the government on board, the penitentiaries. But most importantly, the warden of the first place I worked in just happened to spend a weekend with the warden that was working at the first facilities that we did the pilot project. And he actually said, it's very painful to do, but at the end it was worth it. And he came back a couple days later with a very different mindset, allowing us into the place to do what we were doing. And I think the other thing is we are working alongside them. We are listening to their requirements, their concerns throughout when we're implementing anything, which helps. At one time, we actually came into a situation that we had to correct just when with the prison guard wearing their PPE, they went to an area and was attacked. And because they were attacked and they were not able to actually access their instruments to actually stop this person from attacking because it was underneath the PPE, we had to adjust to saying, no, you can actually keep the stuff outside of your PPE. You just have to clean it afterwards. So we had to make adjustments as we went on, but we definitely listened to them.
Thank you very much. Paloma, please.
Can you see my screen?
No?
Bueno.
Paloma?
Yes.
Do you want to send me the presentation by... No. Now we can see it. Yes.
Now, do you see in full screen?
No.
Yes.
Now we see it full screen.
Okay. Okay, good afternoon, everyone. My name is Paloma Rey from SAMUR Protección Civil, which is the EMS operated in the city of Madrid. First of all, I would like to apologize on behalf of my colleague, Paloma Mirabet, who has an unexpected and urgent situation to attend to. For that reason, I will be the one presenting this afternoon how SAMUR Protección Civil adapted to an extreme and unusual situation during the first stage of the COVID-19 pandemic. Specifically, I will share our experience at the improvised hospital set up in a fairground in the city of Madrid to care for COVID-19 patients, and how we coordinated with other healthcare professionals who were not usually involved in emergency care. Very briefly, SAMUR main's work focuses on providing emergency and psychological, medical and psychological care in the city of Madrid, as well as coordinating and responding to disasters, mass casualty incidents, and foreseeable risk situations in the city. In addition, SAMUR is responsible for managing and organizing the Civil Protection Volunteers Corps of the city of Madrid, and for delivering training not only to volunteers, but also to medical and non-medical professionals and the wider community in first response to medical emergency. So we were not at all used to work in this type of scenario like the COVID-19 pandemic was. First of all, in terms of preparedness, we strengthened our internal CBRN training, building on previous courses. We also developed specific COVID-19 guidelines covering aspects such as self-protection and the management of PPE stock. SAMUR CRVN team established a decontamination line, while at the same time we implemented a strict infection prevention and control measure for our staff. We also had to reorganize personnel schedules in order to guarantee continuous coverage. And we share daily operational and scientific updates with our teams, both by email and in daily shift briefings. And finally, in the initial response phase, one of the key elements was ensuring effective coordination across all teams and other healthcare services involved in the control of the pandemic, especially those working at IFEMA. So what is IFEMA? IFEMA is actually a large fair and exhibition center with 13 pavilions, and it became an emergency solution to the shortage of hospital beds. While more suitable pavilions were being prepared, the first hall was opened on March 21st. At that time, it was simple and open space, and you can see in the picture, with no partitions at all, equipped with rows of beds, each with a single oxygen bottle, and organized into several wards to distribute patients. After the opening of this first hall, another two halls were opened on March 26th and March 30th. These ones were fully equipped with proper beds, partitions, and central oxygen supply, and even ICU beds. So what did we do in IFEMA? What SAMUR did in IFEMA? Well, mainly tasks that we don't usually carry out in our everyday work, like manage the admission ward and carried out the triage. We took charge of the night shifts together with SUMA 112, which is the other pre-hospital emergency service in the city of Madrid. And this required close coordination. The day shifts were covered by general practitioners and nurses who normally work in primary care facilities and not in hospitals. We also were responsible for logistics support and running the pharmacy at IFEMA. We also provided logistics support for medical sessions and delivered self-protection training. Another key task we had was helping the morning shift at IFEMA with the contamination. These shifts, as I said before, were covered by general practitioners and nurses from primary care who had no training in donning and doffing PPE, and their anxiety was extremely high. At first, it was very difficult because they lack confidence and there were several crisis situations. But day by day, they improved, gaining confidence as we guided them through the process. Later, when the contamination station was closed, this created another moment of stress because many still didn't feel ready to don and doff alone. So we stayed close at the beginning and the end of the sheets to reassure them and make the transition easier. Somebody's with the microphone open. Okay. This graphic shows the first moments of the pandemic. The arrows highlight the timeline when the IFEMA field hospital was operating. As you can see, it was opened at the moment when infections and deaths were rising completely out of control. In just 42 days, more than 4,000 patients were treated. That represent about 12% of all COVID patients in Madrid. And what is most remarkable is that 99% of them were able to go back home after their stay at IFEMA. More extraordinary activity of SAMUR related to COVID-19. Well, we also manage the so-called COVID bus, which was used to transfer patients from overloaded hospitals to other that were less saturated, from hospitals to IFEMA, from IFEMA to hospitals, from IFEMA to patients' homes, from IFEMA to medicalized hotels, and from medicalized hotels back to IFEMA. During the COVID crisis, several hotels in Madrid were transformed into medicalized facilities. They were mainly used for patients with mild and moderate symptoms who didn't need hospital admission but couldn't isolate safely at home. These hotels provided medical supervision, medication, and basic care, while at the same time helping to free up hospital beds for the most severe cases. They also act as a step-down facility for patients leaving hospital, but still requiring monitoring. So the main conclusions and lessons observed are that during the response, emergency staff demonstrated their strong ability to adapt to diverse situations, but continuous training for professionals proved essential. Regular briefings and updated information helped to maintain staff confidence and calmness. Coordination with other emergency medical agencies must be ensured on a regular basis. Operational aspects such as PPE stock management, personnel scheduling reorganization, and the role of the CVRN SAMUR P.C team in supporting less experienced staff were crucial. Challenge included the risks of accidental contamination and different forms of stress, psychological stress, thermal stress, and security stress. had to be managed throughout the operation very often. So that's all from my side. Thank you very much for your attention.
Paloma, thank you so much. A short question. When you say changes in the schedule of work, can you please elaborate a little bit more about that?
Yeah, because we need to cover another task beside the regular operation in SAMUR, because emergencies is still ongoing on the streets in a very slow, at a very slow pace, but we need to cover the regular activity of SAMUR. And besides that, we need to help in the contingency hospital in IFEMA and cover all the shifts in the hospital. So we had to reorganize of the human resources department went crazy because the reorganization was huge.
So you didn't scale down your regular operation?
No.
That's amazing.
No free days, no vacation, no nothing for anybody.
Okay. No. So this is the opportunity for our participants, and we have more than 40 online, to post your questions, doubts, things you would like to know. In the meantime, I will ask the three of you. Paloma, if you can stop sharing, please.
Mm-hmm.
Yes. I will ask the three of you one most important lesson observed from your side, or take as now in conferences they ask you take home message. What would be your take home message from COVID-19?
My take home message would be the coordination with other organizations that you may working with, like other EMS hospitals, and is essential to be to practice this coordination on a regular basis in order to be prepared when a big event come.
Thank you, Paloma. You know, that would be a great issue because we will have to give up our ego. And for that, we will need more female leaders in the organizations. Keren, what would be your take-home message?
I think that the key message is that expanding the health workforce in emergencies goes far beyond adding manpower. It demonstrates resilient learning and adaptive health system made possible through strong nursing leadership, as I said before, and broad collaboration. This is my key message.
I would just say something in favor of our nursing division. And Keren is laughing because we normally don't do that. And I was in the room when her boss, Dr. Goldberg, is sitting in front of the Director General of the Ministry of Health. And he says, okay, Israel, in 2 weeks' time, will have vaccines. And we need to vaccinate. And she looks at the Director General and says, sir, if you think I have nurses to vaccinate, you are wrong. And you see him getting pale and saying, what? And she says, don't tell me about nursing students. They are already working. Medical students, they are already working. We just don't have nurses to vaccinate. And then she looks at him and says, but people who are medics or EMTs can vaccinate. We will work out their training program. We will define whom they can vaccinate and whom not. And I have to say, fragile patients, only nurses vaccinated. But at 20 years old, as she said, a 20 years old healthy person, there is no reason to take a registered nurse to vaccinate. The nurse will supervise, others will jab the person. And this is, people ask us, how did you manage to vaccinate so many people in such a short time? And that was thanks to the leadership of nursing division, and more important, the vision that it is a combined effort of everyone, and we are not on professional jealousy, and we are trying to do the best for our population, and that's something that we will at least will not forget. Christine.
I think you alluded to it. I would say adaptability. I think that adapting to the situation, adapting to new information, adapting what you think is your role to whatever needs to be done. I tell people that no matter what job I have, no matter what the terms of reference they give me, the terms of reference really says, do whatever you do to make this work. Whatever function you have, whatever role, whatever mission you have, if you can adapt to your role so that it just makes it function.
Great. Last opportunity for questions. I have 3 pages of lessons that I wrote down that I think hopefully the next pandemic will not be on our shift. So, so we I think have the obligation to leave a legacy, and for me to leave a legacy is really to put down this kind of ideas that if you have a vision and a system which is agile enough to bring in people, and I would just point out that Keren pointed out that yes, we brought medical students and nursing students, but at the same way we brought people who retired, who left the systems, and we were not shy to accept volunteers, and that's a vision, and the idea that okay, we understand, and as Paloma said, that we have people who are not that experienced. A nurse in a hospital that you say PPE, she would laugh because she does it every day. If you're working in an internal ward in a hospital, you are doffing PPE every day. In the EMS, every second day. So, but if you take a nurse who is child care in a primary clinic and you say PPE, most probably she will first faint, just of the idea. She saw it last time when she was a nursing student. And what Paloma was alluding to, that we need to be there to help them because we're familiar and they're scared, and we need to admit that. We need to admit their fear and help them go through it, I think is essential. And Christine, your examples about penitentiary, really, I never thought it's possible to come to the penitentiary guys and say, okay, we will discuss with you the way you go into the ward and you go out of the ward and your inmates go in and out. I thought that this is non-negotiable, period, full stop. You are not telling me how to run my inmate ward. So it's doable. It's an issue of approach. So thank you so much. Lisa.
Fine. Just one statement. I don't know if you know that our director general says that our health system is shaped by the nation emergencies. And that is exactly what we are experiencing here. And Dr. Shoshi Goldberg stands firmly alongside this statement.
Yes, we feel that part every day with the remarkable way that nursing division is doing. I just have to say, why did you change to Achayut? You are muted.
It's not sounds. It sounds. In Hebrew, it sounds nursing. It sounds like
geriatric nursing, I know. Yeah.
Yeah, or something like this. But so that's why we changed it.
We will find a better word with your permission. Lisa, please.
Thank you. But before we close, there's one question in the chat.
I'm not seeing that.
Let me address it. It says, a question addressed to all. Did you need to modify your standards of care? And if so, who authorized this process?
Please, Keren, Paloma, who authorized the changes in the normal protocols?
The city council responsibles, because we are a municipal service. So the mayor of Madrid authorized to modify the standards because it was an emergency in Madrid. So he was the mayor.
I would say on behalf of Magen David Adom as an EMS that in our case the process is rather simple, and it is the Deputy Director General of the Ministry of Health who is in charge of the healthcare standards in Israel. He is the one who would sign changes.
There is a committee first that combined with the nurses and the doctors, and then it goes to the general director and for the last decision about these protocols.
At the end of the day, the important thing is that it is a structured decision which applies for everyone. Because at the end of the day, we cannot have a system where I would decide that saturation of 94 is good enough. One hospital would say, no, for us it's 95, and the other one would say it's 92. We need,
this is correct.
We need a standardized, and that would be always a decision of the Ministry of Health.
In my situation was quite different in terms of standards of care. I think the biggest thing that we actually had to lower our standards were the lack of PPE. So it meant that we couldn't don and doff gowns between residents. The first place I went to, they literally said we only have enough for one per staff member for half the day. They literally could change. So we tried to adapt it to make it practical and made it so that the flow was one way. You would go from green to yellow to red, and then you change out and go back to green, and then that would be half the day, and then the other way around. But it was not ideal, but we had to do it that way. It was a decision that was made at the facility. We did not have to go further to actually get approval for that.
Yeah. Lisa, please.
Okay, thank you. Thank you to the speakers. The presentations were very, very interesting. Also, thank you very much, Chaim, for the lovely moderation. That's it for today, but we are coming back. So our next webinar is on the 2nd of December at 5 p.m.
December, Lisa?
Oh, sorry, October.
October.
2nd October at 5 p.m. Central European Summer Time, and the topic will be on work-life balance, moderated by our Portuguese colleagues. So if you're interested in this topic, please follow us, join us, follow us on YouTube, also on LinkedIn and on our webpage in the Knowledge Network. My colleague was so kind to share the certificate link also in the chat, as well as the QR code, depending what suits you better. And with that, thank you very much and have a nice evening.
Thank you.
And because next week is our Jewish New Year, I would wish you all a happy New Year, full of good deeds and saving lives. Thank you for what you're doing.